segment. Zach, I need you up here, please. So on our next slide, we'll be talking about the cranial valve. Please be aware that cranial valves, yes, you should know all the cranial nerves and where they insert. You should know about all the vertebral areas and also all of the arterial components that occur there. But what I want you to understand is when you're doing palpation, as we're placing our hands behind the neck, first thing I want to do is call the Scully's exam, and I'm just going to press down. So when I do that, if they see any nystagmus in the eyes, I know that probably under compression, they've had some form of concussion or they've had some form of head trauma. Because almost always you will get an OA and an AA reaction. Those are compression points that are formed from the concussion. But you're palpating the occipital notch in the back, and you're also palpating the vertebral artery. Be aware that when you're touching that, don't try to bring your thumbs in front of the face. Try to keep your hands away and allow your fingers to feel the pulse. And then on the cranial exam, we're just going to do a very simple range of motion. So flex forward, bring your head all the way back, as far back as you can go. All right, watching for nystagmus. Turn your chin to your shoulder. Turn your chin to your shoulder. So we've done C1, C2. Bring your ear to your shoulder. Bring your ear to the other shoulder. A little stiff, huh? Okay, all right. So let's feel that. We notice that he's got a little bit of a left side occurrence, and I want to feel for the spinous process as well as the vertebral processing the vertebrae, and feel for any anomalies. You're feeling for a crepitus and you're feeling for a crunching sensation. That you'll also feel for like a bulge. If that bulge palpates your finger, you'll feel it push into your finger quite quickly. If that happens, you know that they probably have had a neck injury. Have you had a neck injury before? Mm-hmm. Did you get into a car accident? Mm-hmm. How long ago was this?
About 6 years ago.
And have you had any physician care for this?
Yes.
And are you still in physician care?
No.
Okay. Did you do any physical therapy for it?
No.
No. Why? Don't know. Good answer. Okay. Just because you go to the doctor doesn't mean you go somewhere else to get it taken care of. That includes physical therapy or occupational therapy or even athletic training. Okay, if this was my athlete, I'd probably set them off to the side and do a complete neck exam. We're not going to do that today. All right, so now the next segment we're going to do is C4. Bring your shoulders up in your shoulder shrug. All the way up, hold, relax. Now grab a hold of the elbows, pull up into shoulder shrug again, and you're resisting while you're doing that. C4, C5. Bring your arms all the way out to the side. Hold. Okay. Now, so C5 and C6 actually innervate each other. So when you do this, you're also going to do internal rotation and external rotation. So we're doing for supraspinatus, pull your thumb towards me. Everything we're doing is bilateral, by the way. Bring your thumb towards the wall, back. Come on, come on, come on. Infraspinatus is almost always weaker. All right, bring your elbow down to the side. Bring your thumb out towards me. Go. Now bring your thumb towards your belly button. All right, so we did teres minus and subscapularis. So we've done all the rotator cuff. We also want to look for any anomalies on the shoulder. So we're looking for shoulder height, AC height. You hurt your shoulder before, haven't you? Mm-hmm. Good job. Okay, start at the sternoclavicular joint, follow along the clavicle till you get to the AC. Push down on the AC. If they bounce, that's good. If they go boing and they stay there, not good. All right, you want them to go up and come back down. So that's piano key test. Grab all of the elbows, pull down slowly. You'll see a little dimple on the shoulder. I'm going to pull your arm up. All right, relax. Okay, watch it again. You see a little dimple, and then it goes back up to normal. That sulcus sign. Bring your arm here. What I want you to do is I want you to bring your thumb to the ceiling and your arm to the ceiling. Ready? Go. Hopkins-Kennedy test. Hold down. Hopkins-Kennedy test in reverse. They have pain on the front part of the shoulder. That's an anterior labral tear. Almost all throwing and hitting mechanisms occur because of the anterior labral. So make sure that you test that. Find the AC joint, go one thumb's distance down. Do not push hard. That is a coracoid process.
You do that, they're going to cause a little winching. What I want you to do is put your thumb on the coracoid process, bring your hand up to the ceiling as fast as you can, go. Obviously, call the speed test, a little sore. And the reason why that's sore is because the brachial-brachialis as well as the biceps tendon insert onto the coracobrachialis, and that is bicipital tendonitis. Also a good indicator of some form of an anterior labral tear. So if this gets worse or that becomes very, very painful, stop your evaluation, do all your shoulder exams, or send them off to orthopedists. Okay, so those are the shoulder and the cervical. We've done all the rotations. So next slide. All right. Now, one of the other things about the shoulder evaluations, especially upper shoulder, is that when you're dealing with anterior posterior drawer, you can do that on every single joint. The sulcus test is a very easy test to test for anything like dislocation or dysfunction. Don't get too crazy about that. Kids that are between the ages of about 11 to about 14, especially if they're male, are going to have a very distinct sulcus sign. Females typically don't, and the reason for this is because they have a higher tenor stage. If they do have a sulcus test where you pull down on their shoulder and you get that dimple and then that arm just stays there, chances are it's already dislocated. So try to put it back and then ship them off. The sulcus sign, if it involves pain, will almost always be labral or glenoid directed. So a glenoid dysfunction in a 13, 14-year-old is probably because they started throwing the ball at 5 or 6, and they started throwing the curveball at 7. And now they're in high school, and they want to play baseball or they want to play football. Well, guess what? The shoulder is probably destroyed. And that's when we go down to the elbow, and we'll probably see the same thing there. So let's go to the next one. All right. So we've done all the palpation across the coracoid, across the clavicle to the AC, down across the shoulder and the glenoid. Palpate the back side of the scapula and follow the scapula all the way down the vertebral border until you get to the apex. All right. Now have them bring the opposite arm up. There you go. If that shoulder blade stays stable, we're good. Put it down. If that shoulder blade rotates, especially towards the scapular spine, then we have a dyskinesis. And when that happens, we have a lot of weakness in the back and the muscles in the back. Almost everybody works in the weight room. They work on the chest. They work on the quads. They forget to work on the back. Unfortunately, you can go forward, but you got to stop sometime. Okay, so follow the apex, follow it back up along the axillary border, then follow along the biceps. Now, where the biceps and the deltoid come together, there is the deltoid tuberosity. The deltoid tuberosity is a good indicator of any pain or dysfunction of the shoulder. When you hold on to that with your thumb, bring the elbow out, and that causes that shoulder to dip, so it does this, all right? That is a good indicator of a shoulder dislocation, and they probably need to have some rehab. All right, the elbow, very simple. Don't let this freak you out, all right? It is just a simple hinge joint, all right? That's all it does. It don't do nothing else. The arm, unfortunately, does all the rest of the stuff. The elbow just hinges. So feel the equinoid process on the posterior aspect of the elbow, where my finger's at. Feel the medial condyle, run your finger across it, go down until you feel a little groove. When you get to that little groove, play with it. If it makes your pinky go kind of numb, that's good. That's your funny bone. You're supposed to have that. Okay? Go to the lateral condyle and feel just into that groove. And if it makes your thumb go numb or feels it tingling, that's good. That's radial artery. You're supposed to do that. Okay. All you need to do on this is anterior posterior drawer. So you just grab a hold of the upper portion of the humerus, all right, and you pull forward. If it stops, good. If you push back and it stops, good. If it keeps going, put it back. All right? Valgus and varus stress. Valgus is starting with a lateral force going to the medial side. So you're testing for the ulnar collateral ligament. You keep it bent at about 20 degrees and you open it up. This hand is doing all the work. This hand is the stabilizer. That's all we're doing. So then we rotate and do the opposite side. See where I have my hand, and I'm just going to do that. So that's varus force, anterior posterior drawer. So now, You can do anterior, posterior drawer, you can do valgus and varus glide, and you've done the other two things, which is supination and pronation. Put your hands like this. Say, please, sir, may I have some more? That's supination. All right? All right? Supination has to occur within the body. So it has to maintain within the supine portion of the body. So when you go in supination, your thumb is going to be lateral. It's also anatomical position. All right? So when you go pronation, now when you rotate your hands in, you want to see how far they can turn. So turn them all the way in as far in as you can go. You notice that the elbows come out. Well, guess what? That's because of the teres minor and also some of the flexor tendons. All right, that's normal if they're flat. Some females may have, turn your hands into neutral. Okay, some females, when they bring their hands all the way out into extension, all right, may have a increase of 5 degrees of flexion. Don't let that worry you. 5 degrees of flexion is not that big of a deal. He's at 0. So if you have a little bit more, it actually puts this into extension. This is flexion. This is extension. Okay. All right. So hold your hands out like that. Spread your fingers. Okay. Now I'm going to lock my fingers into his hands. Come on, put your hands out. Good job. All right. Now, bring your hands in. Okay, good. Now, put your hands together. Make a fist. Pull back hard. Pull, 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 pull. You'll also notice that the thumbs come up when I do this. I'm going to do this over here. Watch. Squeeze, make a fist. Pull in. See how the thumb comes up? Okay. The reason why the thumb comes up is because the thenar muscles are extremely weak. And so don't let that freak you out. So what we've done here, when we pulled in, we've not only tested C6, squeeze, make a fist, C7, pull in as hard as you can, C8, T1. All right? So we've done all that. Next one. Okay. If you want to make a lot of money, go into hand therapy or go into hand position. The reason for that is because there are 70 different things that go on the wrist that most people don't even pay attention to. But here's how easy this is. Scaphoid lutein, carpal groove, thenar, hypothenar. So let's do it again. Scaphoid lutein, carpal groove, thenar, hypothenar. If you can palpate all those and everything feels normal bilaterally, then we're good. So we do extension, flexion, ulnar deviation, radial deviation. Now, we can do thumb in to your pinky, okay, thenar and hypothenar surfaces. All you're looking for, put your finger and your thumb together, all you're looking for is this nice little groove right here. If you've got that, then we're good, all right? Manual directions or manual resistance, bring your hand up into extension, bring your hand down in flexion, pull your hand towards your thumb, bring your hand towards your pinky. All right, now, Phelan's test. All right, fingers. All right, bring your elbows in, your wrist all the way in. Okay, now hold. Hold. Good. All right. Now do Carvin's test. Squeeze the carpal groove. All right. And now bring your hand all the way down to extension. If you lose the pulse, they have Carvin's. Plus, you'll see the fingers turn blue. Okay. Pinch grip test. Pinch. Okay, good. Pinch. Good. All right. Anterior posterior drawer test. This is the fun one. On males that do a lot of weightlifting, you're going to see this move a lot. See how much motion he has on there? Okay. All right. Now, bring your hands together. Okay. Do you lift weights? Do you try? Okay. All right. All right. I'm trying to be a smart aleck. I got it. All right. Pull your hands apart. Look how big he is compared to how big my hand is. Watch again. Pull apart. See how much strength there is? All right. Remember, you have the anatomical advantage on this patient. All right. So what they're trying to do is go, pull everything apart. Don't let them freak out. It's going to be okay. I do this all the time to my football players, especially my linemen. Go ahead and pull your arms apart. All right. Don't bring your elbows in. Don't cheat. Pull your arms apart. All right. Good job. Keep jumping. All right. Yeah, you think you're tough and stuff, and then you get an old man that beats you up. Okay. All right, next slide. Okay, go ahead and lay down for me. It doesn't really matter. I need you close to the edge of the table. Let's bring your head a little bit farther up. Okay. Okay. You can do the pelvic eval very, very easily. From the belly button to 4 inches down the thigh, belly button to 4 inches down the thigh. Outside of the hip is a box. Your hands should never go into the box for any reason whatsoever. Why? A, you don't need any more lawsuits. But anything from here down to 4 inches down can all be tested without actually touching it, because you can see the range of motion. So we know that we have the iliac crest. We know that we have the acetabulum. You know you can palpate the femur. That's really all you need to do. If you want to flip them over and check the PSIS, well then happy campers are us. Remember, always use the palm of your hand and not your fingertips. All right. So when we're looking at the sciatic notch of the femur, all we're looking for is basic range of motion. So if you bring your knee up to your chest, good. Bring your other one up to the chest. Good. Are they equal? Chances are there probably are. All right, bring this leg up straight. Okay. So we're about 60 degrees and he's starting to shake. A, he has really tight hamstrings. Every teenager on the planet will have tight hamstrings. Don't let that freak you out. Okay? So what we want to do is bend this knee. Now bring that leg up straight. Aha! Now relax. Now we're at 90 degrees and we're good. So we want to check bilaterally. All right. Well, here's where the sciatic comes into play. If I bend that knee and I bring that foot up as far up I can go, I can test where the sciatic nerve is. If I push it all the way up like that and their butt cheek starts to go, that means their sciatic notch is a little tight and their sciatic nerve is a little irritating, which means they need to do some back strengthening, and they probably need to be looked at very easily. Okay, abduction, adduction. A, B away, AD in. All we're looking for is to see if it's equal on both sides. Cross their leg, let it drop. Let it drop. Oh, it is. Okay. All right. So Patrick's test. It's actually considered Faber's and Faders, which is flexion, abduction, external rotation, flexion, adduction, internal rotation. So that's where Faders and Faber's comes from, but it's actually part of the Patrick's test. We can do that along with a femoral glide the whole time. So all we're doing is to see how much strength we have going in. Bring your knee towards your chest. Okay, now bring it back down. Nope, bring it down. Knee down, like that. Okay. Ready? Go. Okay, so we've tested for flexion, extension, abduction, adduction. Now we test for internal and external rotation. Bring your toe towards your head. Good. Now bring your toe towards my arm. So we're looking at here and here. Okay. If you're going to be doing evaluations or pre-participation exams on females between the ages of 13 and 16, and they are in cheerleading or gymnastics of any kind in their lifetime, they will have extreme flexibility when it comes to internal rotation, but very weak when we go into external rotation. So they could do this, they could probably put that heel all the way up there on their shoulder, but they're not going to go past 45 degrees on their hip.
Now, what does that do? It loosens up the acetabulum of the hip. It loosens up the anterior labrum of the hip, and they have a greater propensity towards anterior labral tears when they go into other repetitive sports. So be aware of that. Okay, iliac compression. All I'm doing is putting my hands on the iliac, and I'm going to go one side, down the other side, and down both. So I'm feeling down, down, down. It should recumbent back very easily. If it doesn't, then we probably need to look at the pelvic, probably have some x-rays taken or an MRI. We probably have a PSIS or we have a torn labrum. A very good example of that. All right, femoral glide. So I'm going to step here. Bring the feet together, toes up. Now what I want you to do is I want you to bring your feet together as hard as you can against my hands. Go. All right, one thing you're going to notice is right here along this midline, you will watch the muscles of the quad as well as the lower abdomen tighten up. So watch again. Tighten, go. See how the tummy tightens up and the quads tighten up? Okay, that's a good sign. Now bend your knees. Okay. Put your hand in between the knees, squeeze. Squeeze. Okay, now relax. Do it again. Watch the tummy, watch the quad. All right, now we bend the knees all the way up. Do it again. Squeeze. Tummy tightens, quads tighten. Okay, relax. So we've tested gracilis, adductus magnus, adductus longus, and adductus brevis. The only thing we haven't done is test peroneus and piriformis. You probably don't need to do that because you already tested for the favors and faders, which will tell you that if you had a weak piriformis, they probably couldn't externally rotate their leg anyway. Okay, knee, next one. All right. In my professional opinion, the knee is the easiest evaluation on the planet. A lot of doctors will say no. Why? Because there are 8 degrees of motion that you can get on the knee. Flexion, extension, external rotation, internal rotation. You can also get anterior posterior glide, and you can get anterior posterior rotational instability. Okay, that's all you need to worry about. So, does the knee bend or flex? Yes. Does it do the same thing on the other side? Yes. Medial condyle, lateral condyle, patella. Does the patella move back and forth? If it does, that's good. If you slide it over one side and you feel a crunching sensation, they probably have subluxed their knee sometime in their life. Okay, there is a test called the Clark's test. Now, if you're working with teenagers and you think you want to do a Clark's test, don't. Every teenager has chondromalacia. Why? Because we spend all of our time playing on video games, watching TV, and playing with our phones. We're not out running, hopping, skipping, jumping, and we're probably not very active. Well, this is why we're doing this. This is to tell them to get out. So you just take your thumb, put it on the top of the knee. Now tell them to tighten up the quad. Hear that? Okay. You probably didn't hear it. I felt it. There's a... If you do that to an older person, i.e. coaches, which I love to do. I have bring a coach in and have them do the evaluation so all their athletes can see them. When I do that to a coach, they freak out because they're really old. And they have arthritis and they have all sorts of problems. All right, you don't need to do a Clark's test, but if you think that the kneecap, can I bring this up? Where is it? Unzip? Okay, awesome. All right, so if the kneecap is here square, if it tilts to one side, especially medially, then we have patella baja. If we tilt laterally, then we have patella aha. Don't get weaked out. Okay, the patella is supposed to glide up and down on the femoral groove, but it glides at a 15-degree angle. All right, so when I bring that knee up, that kneecap should be glided over about 15 degrees. That's normal, and it should be resting perfectly inside that groove. When we bring that kneecap over, it should glide very easily laterally, but very difficult on medial side. So when I do a Clark's test, I want to tighten up your quad. It should glide a little laterally.
That's called lateral riding patellae. They can do treatment for that. You can do that in the athletic training room or at the physical therapy center, but you can also do a lateral release. Please do the physical therapy first before you do that. Okay, Gertie's tubercle is right on the lateral border, and that's for the IT band. All right, you need to palpate that and have them bend the knee just slightly and see if that IT band is attached. All right. On the medial side is the pes anserinus, that is the semitendinosus, sartorius, and the gracilis. Those are all adductor muscles and abductor muscles of the leg. So on the pes anserinus, there's a little squishy spot. That's a pes anserinus bursa. That's normal. The tibial tuberosity, just above that is the patellar tendon. And then the patellar tendon is it's actually a ligament, but the patellar tendon also has a very large bursa. So if it's inflamed, you'll see this squishy spot on both sides. So when you push on it and it squishes, they probably irritated the patellar tendon. There's also the anconeus bursa, which is located on the top of the knee, and that is typically due to like ACL tears. All right, stress exams. All we need to do is valgus and varus, and then we can do some anterior and posterior drawer. So valgus, once again, 0, 20 degrees, and then varus, 0 and 20 degrees. Okay, it's supposed to stop. If it stops, that's good. If it goes and then comes back, that's grade 2. If it goes and it stays there, it's grade 3. Put it back, send it to the orthopedist. All right? Now, there is a lot of people that say you have to do the anterior posterior drawer and Lachman's exam. All right, I have tiny little hands, and I have learned a lot of different mechanisms of doing the Lachman's, the test for the ACL and test also for the PCL. But there is a very simple test. It's called Yelley's exam. It's not on the list, but watch. Put your hand right into the belly of the muscle. Then take your hand and put it on top of the knee. And then all you're going to do is push on the knee. See how the leg comes up? Comes fulcrum. That means the ACL and the PCL are attached. If you push down and that heel stays on the surface of the table, you will see the tibia rise that direction. And when that happens, they have a torn ACL. It has a greater propensity for validity on testing than does the Lachman's, which, by the way, is at 20 degrees, and you're doing this. But I've done a few in my lifetime, so I know how to do it. Okay, sag test. Hold the ankle, relax, drop. If it goes, it's sag, that's a PCL test. Pivot shift, I'm going to place my hand on the lateral border, and then I'm going to turn into a medial condyle, and I'm going to shift down. If it drops and goes medially, MCL, ACL, PCL, probably medial meniscus. All right, McMurray's test. McMurray's test, you put your fingers along the joint line, and then you turn the toe in, and you go in. And then you turn the toe out, and you go out. And all you're feeling for is an audible and a palpable click. If you feel that, it's probably meniscus. You ever hurt your knee before? This one? This one? Okay. Were you running at the time?
Yes.
Okay. Because you had a little bit of a click. Yeah, you do. Can you hear that? Okay. Everybody in the room heard it. Okay. So he has a lateral meniscal, probably a start of a bucket handle tear. He could probably continue doing exercise and doing activities, but what's probably happening is he's probably overriding his lateral border. So he's working really a lot on his quads to get his quads stronger, but he's not working on his hamstring. It's obvious because he only has about 60 degrees of hamstring flexibility. See how his knee bends? Okay, probably not good. So he needs to work on his hamstrings, and that'll get rid of that knee problem. Okay, next one. Okay. Follow the tibia down, all the way down to the leg. The fibula actually fits into the femoral groove. And there's a little condyle right off the tibia. And you find the fibular head, you can run it down, follow it all the way down to the lateral malleoli of the ankle. All right, I'm going to pull the sock off, all right? There, you're good. Okay, so fibular condyle, tibial condyle. If you place your finger underneath both of them, and place your finger down, right in that center is the talus. Put your thumbs on top of the talus. Put your hands around the heel, and then push down. All right, anterior posterior drawer. All right, so you want to do inversion? You just turn in. If you want to do eversion, you turn out. If you want to do distraction, just pull away. All right, so most people sprain the anterior talar fib ligament 75% of the time. And that occurs with inversion and plantar flexion. So if you just do the tib tilt test, it should open up and there should be a divot. If you go the opposite direction, that's the medial, which is going to be the deltoid ligament, only happens 10% of the time, and they have to have their foot everted and dorsiflexed. And that's very hard to do, even in athletics, okay? But there's a test for that. It's called the Kleiber's test. Sit up for me. Okay, let's pan down. Okay, Kleiber's test. Right on top of the talus, right on top of the calcaneus, pull down, invert, evert, invert, evert. You sprained your ankle before too. You're just a mess. Okay, so you were running and you landed on something like a hole or a rock and you inverted your foot, but then you popped your foot right back up and then it swelled up right across the top of the joint line, didn't it?
It was soccer.
Yeah. All right, good job, Lisa. All right, that's actually not a bad ankle. I'd probably wear support of some kind, like an ankle brace of some kind. All right, so pulling this off, giving that back to you. All right, look at the foot. See how there's an arch? All right, that is a functional arch. So if I let go of the toes and it flattens out, then that's called a supple flat foot. When they stand up and it stays flat, that's a functional flat foot. Supple flat foot can be treated with orthotics. You go to Walmart, you step on the scale, you get the little thingies, you get your number, and you walk down to the cashier, you pay for it, you walk away. You don't have to spend $165 on orthotics. If it's a functional flat foot, you're going to the orthotist, and you're getting some orthopedic orthotics that are put in. Okay, so how do we know the difference? Stand up for me. Can you get all the way down? Kevin? Nope.
That is as far as we can go.
Okay, sit up here. Sit up here, go all
But
the
I
way.
didn't know like where your foot is.
All right, step forward, step forward, step forward. There, good. All right, so what we're looking for is to make sure that that has a little bit of an arch. All right, now go up onto your toes. Does it have an arch? Yes. Come back down. Does it have an arch? Awesome. Okay, next slide. Okay, balance and coordination. Believe it or not, most teenagers do not have a problem with balance, but they do have coordination skills that are a little bit questionable. One of them is the double leg standing. So bring your standing this way. Let's step forward just a little bit. Okay, now put your feet together. Now, what I want you to do is lean forward and touch your toes without hitting your head on the table. Oh, we got to stretch really good. Oh, we were looking at the spine. So looking from one side higher than the other. He's got a little scoliotic reaction. Some people may call this kyphoscoliosis. Don't let that freak you out. It's just a raise on one side stronger than the other. Come on back up. And the reason for this is because he's right-handed. That's the only reason why. Okay, reach down, touch your toes again. You put your thumbs right on the PSIS. Then when you stand up, it equalizes. Everything goes back to neutral. And we're looking from the top all the way down to the PSIS. All right, so now squat. Without, no. Put your feet together and squat.
Okay. That just moving away from the table just a little bit.
Oh, so his heels came off the table. Did you all see that? Stand back up. All right, go back down again. Heels come up. What does that tell you? Oh, that's right. We talked about this. Hamstring strength. we have some very tight hamstrings, and so therefore the lower legs have to have that reaction. Now what I want you to stand up, spread your feet like you're going to do a squat. Turn your toes out to about 45. Thank you. Now squat. Oh, the heels stay to the ground. So somebody learned how to do squats when they were in the weight room. Stand back up. Okay. Same position. Now instead of squatting, I want you to bend forward. Oh, a little tight. And once again, we have a little kyphoscoliosis. But when we put our thumbs on the PSIS, come back up. See how we went straight over to the other side? Okay, so that tells me that we're riding laterally to the side that's irritated, and that is probably due to muscle strength and muscle weakness to the opposite side. So now, put your feet together, arms out to your side. Let's bring it up just a little bit, Kevin. A little more, a little more. Yay, now thumbs up. Okay, close your eyes. You want to push on a little bit, see if they stay there. Keep your eyes closed. Don't be cheating. All right. Now raise your right leg. We're looking for a massive balance dysfunction. All right. Now raise your left leg. One touch, two touch. If they touch more than 5 times, chances are it's because they're right-sided or they're left-sided. So left-handers are really going to throw a kink into your system. All right. This is known as Romberg's test. Now, there's something else I can do with that too, and that is have them take their index finger and touch their nose. All right? All right, close your eyes. Go. All right, back, this side. All right, now, I want you to raise your right leg. Come on. Now, touch your nose. Okay. Okay, that's part of the other testings that we do. So go ahead and put your leg there. All right, so we are doing a little bit of testing for Romberg's test, which will also test part of the SCAT-5. For those of you that are not familiar with that term, that is the concussion evaluation testing that has gone through the Berlin segment, which was done in 2016. And that is now called the SCAT-5. You can download that as a free app. You can also download the paperwork. It is a little lengthy in angle. Okay, so let's sit back down. All right, leg length and arm length. What we're looking for is, are their arm distance farther than their height? You also want to look for the choriolis, or you want to look for some sunken chest. Check and see if their eyesight is narrow. Is it myopic, or they have like any form of dysfunction with their eyes? If they're wearing glasses or contacts, check for myopia or diopia. If they're myopic, they're probably nearsighted. They have really long arms and they have a sunken chest. They have really long fingers that are comparable to the rest of the body, where they bring their thumb and the thumb extends out over the edge of the hand. Those are kind of things we need to look for, especially when we're looking at Marfan syndrome. Leg length discrepancy, what I can tell you for most people is, especially if they're teenagers and they're just now learning how to do lifting weights, that their dominant side is going to be longer than their non-dominant side. This is a little bit of an unusual action because of the fact that if their leg length is a little longer, then they're going to start having lower back pain. They're going to have middle back or thoracic pain. So if they come into your office and they say, you know, my back really hurts. Or were you lifting? Yeah. Well, if you're lifting and one leg length is tighter than the other, and you lift up, you're going to go to the side that you're more dominant on. And when that happens, you're going to put PSIS, SIS, ASIS, all that hip is going to transfer back and forth. So those kind of hip dysfunctions can change the angle of the vertebrae. And when that happens, you start having low back pain, thoracic pain, hip pain, lateral leg pain, even you may even getting some radicular pain into the lower leg and into the toes. So you need to be looking at the whole body, not just go, oh, I got back pain. Okay, let's go take an x-ray. Look at leg length first to make sure that one leg is not longer than the other. So a quick way to do that, lay down, put your head at that end.
All right, so once again, we're finding the medium malleolus. All right, bring your feet together, make sure that your thumbs touch. If they do, great. Bend your knees. Bend your knees, good. Heels are in alignment. Sorry, I'm gonna do this. Okay, heels are in alignment. Is this the same plateau level? And is this the same plateau level? Well, we already know he's right-handed. So which leg do you think he's gonna kick with? That's right, his right. Okay, so if the right side is farther up than the left side, that's probably due to right side dysfunction. And that is a derangement, and we need to change that. They need to start being applicable to both sides. If he's a soccer player, which he says he is, he's probably going to be able to kick better with his right leg than he is with his left, unless he was trained to kick with his left and then dribble with his right. All right, those are the good soccer players, by the way. Okay, so if one side is higher than the other and one side is farther than the other, the side that's higher goes on top. And then you just pull down, relax, pull, up, relax, pull, 1, 2, 3, relax, pull, 1, 2, 3, relax, pull, 1, 2, 3, relax. Muscle energy testing, go back down, leg length, bend your knees. Guess what? We're back to the same height again. Muscle energy, and that's how you do that. What is a Q angle? For males and females, remember that the hip on the male is 10 degrees, that the female is at 15 degrees, and that is an anterior posterior rotation. Female hips are a little bit wider than male hips. They're about 5 or 10 degrees of external rotation. So look at the distance from the acetabulum to the medial meniscus, or to the medial condyle of the femur, to the medium malleolus, and measure that length. Then you measure that length. Then the angle for that pull should be on a male, should be around 10 to 15 degrees. On a female, it should be between 15 and 22 degrees, especially if they're teenagers. As you grow older, they get smaller. That's okay, all right? So if you have a female that has a greater than 22% gradient, or a Q angle, you're gonna have knee pain, you're gonna have hip pain, you're gonna have lower back pain, and they're probably gonna have some lower foot pain. And that's because of Q angle. Next slide. All right, now, are there any questions? These are the questions I need you to be able to ask and to answer correctly. Yes, muscle testing is directly associated with joint insufficiency. The muscles are weak, the joint doesn't work as well. So the answer is true. Leg length testing is an efficient method of determining lumbosacral dysfunction. The answer is yes. Hamstring strength is precursor to lower body joint injuries. It's not. It just means that their hamstring strength needs to be worked on. But if you don't work on them, then they'll get better. All right, Marfan syndrome can be identified early through orthopedic evaluation. The answer is yes, you can. Athletes who conceal concussions during didactic portion of the PP is true. There is not an athlete on the planet that will tell you, oh, have you ever had a concussion before? No. You ever felt dizzy? Oh, yeah. You ever had troubles in class where you can't remember what you're talking about? Oh, yeah. I can't remember stuff on test either. Okay, good. All right. Have you ever felt like you had problems with sounds or light that bothered your eyes or had a tingling sensation in your ears, like a buzzing sound? Oh, yeah, I get that all the time. When was the last time you hurt your head? Oh, probably a couple months ago. All right, what were you doing? I was playing sports. What kind of sport were you playing? It's probably some form of a contact sport. Well, guess what? Those are all red flags that should be shown up for concussions. And there is a statement on your physical exam, your PPE, that you can get through the New Mexico Activities Association. Look under sports medicine. You'll be able to download that. And it also gives you the signs and symptoms of concussions. That, by the way, is another discussion. Okay, next. All right, so if you have any questions at all, please, now is the time to do that while Zach takes a little nap, because I worked him out a little bit.
And if for any reason you're not able to use your audio, you can use the chat function. I'm bringing that up now.
Well, I have a question.
Sure.
Not that I want to come on camera for this, but I'd heard a good test also for the meniscus is to have them stand on one foot, bend their knee, and then to swivel.
Yeah, that's a great way to tear the meniscus as well.
Ah, okay.
So probably not a good idea. The other one was called the duck walk test. Stand up for me, Zach, and over there towards the chair. Now squat all the way down, stay down.
Sorry?
Squat all the way down, stay down. Now, stay in that position, come to me. No, stay down.
Stay in the position.
Stay there, come to me, come to Bubba. And you're gonna hear, they're also gonna do that about 5 or 6 times and they're gonna go, oh, that hurts. Stand up. That's called the duck walk. Once again, okay, let me show it to you in real simple terms that even I can understand. The knee fits on top of the joint like this. When you bend the knee at 40 degrees, it glides forward onto the top of the condyle. When you go to 90 degrees, the femur is now sitting on top of the tibial condyle. When you go to 120, it's now resting on the back side of the knee. As soon as you open up that pack, bend at 15 degrees, the meniscus are now being placed under stress on the posterior aspect, which, by the way, is where all the blood supply is at. So as soon as you bend that knee at 15 degrees and you rotate, you're doing that. Now, here's an example. Take your hand, put it on the wall, push as hard as you can, and turn. Does that feel good? If it's on a joint, the answer is no. Okay? So don't do that to a patient. Don't do the duck walk unless you are really sure that you need to have a meniscus test. All right?
Because it's on.
Yeah. If you are sure that there is a meniscus injury or a knee injury, then I would have them do it. But otherwise, I wouldn't. Okay. Single leg walk as well, where they hop on one leg. I probably wouldn't do that unless I am really sure that we're dealing with an instability or derangement of the joint.
So so on these physical forms that we all fill out on the very bottom under functional, there's duck walk and single leg hop. So it sounds like we should just let that go.
We should probably let that go unless you are really sure they have a meniscus problem or a hip problem or they have a joint dysfunction that you're not really sure of, which you probably should do other tests besides just the ones. Those are, yes, they are functional tests. And yes, the American College of Sports Medicine says that the duck walk is a good indicator for meniscus tear. Not for procedure. Okay, let's keep it down. All right, any other questions? Thank you very much for your time. I appreciate it very much. Thank you.
Thank you.
Thank you.
Thank you, Zach.
Ready?
Yeah.